nodule, a rubbery, fibrous tissue-filled nodule that typically occurs after trauma to the ear, so a wound or a puncture of the skin. In fact, it's quite common after ear piercings if they go wrong. This patient hasn't had an ear piercing, but they did say they had trauma to the ear many years ago. The keloid is not causing them any problems whatsoever. Just dried wax. I did clean that up at the end of the procedure. It's just in the conchal folds. That's part of the pinna, the satellite dish on either side of our ears. There's just a bit of wax in there. So it's really impacted this. I've just instilled some medical grade olive oil spray. What the olive oil spray tends to do is binds this soft, mushy wax together, and it just makes it a bit easier to remove. You can see the periphery of this occlusion. There's a lot of dead skin, keratin. It's enveloped itself. So that's that glossy, almost translucent sheet of skin that we can see. I've just instilled some more olive oil. Now, the great difficulty I had here was that it was very difficult to position the endoscope exactly where I wanted it in the ear, because the outer third of the ear canal, the cartilage portion, was quite rigid, more rigid than usual. And normally I'd go into the ear, I'd push the endoscope to the left, in the case of the right ear, and you can see the endoscope's more central here. And when you put the instrument in at the same time, it can be a bit crowded in there. So it's not normally an issue. So to overcome that, a bit later on in the procedure, when I'm beginning to remove wax from the anterior and inferior recess, I've got quite a prominent anterior and inferior recess, I used the new zoom function that we've installed onto the new ClearWax app, which is in the final stages of development now. And what the zoom feature did, it does reduce a bit of clarity, unfortunately. The iClearScope system, we're using the iPhone SE, the third generation. The reason for that is that it's lightweight and not too large. And of course it's affordable, so when we're selling this on a commercial scale, we want to make sure, of course, it's of a very high quality, but also affordable. So there are other iPhones, of course, you can use with superior cameras, but the iPhone SE is more than adequate for performing earwax removal and also diagnostics. So when you zoom in, the image does get slightly grainy, but it did help me a lot. And the reason why it helped me a lot, because it didn't require me to over-insert the endoscope. I could just have the endoscope more lateral near the entrance and zoom in and still have enough access to remove this wax with the instrument. As you can see, I'm really filling this ear with the olive oil spray because of the consistency of this wax. It's so mushy. And as we approach the eardrum, the ear canal narrows. You can probably see that on screen. I'm using the full Zollner at the moment, so there's not much maneuverability available. And I've just got to be careful I don't catch the anterior canal wall with the Zollner. The front section of the ear canal's coming very close. At the moment, the fine end just wouldn't be powerful enough. It will get blocked. So I just want to try and move a bit more. To allow better access. You can see I've zoomed in a little bit now. So the zoom feature I initially developed to work alongside the waxscope, because the waxscope will benefit from having the zoom feature. But in this case, it also became handy when using the iClearScope. So I'm just going to zoom in again, and I think now I'm still using. It's very difficult to tell what I'm using now because I'm zoomed in. I think this is actually a fine end. And this wax is very mushy. It's trapped in the anterior recess. So as we approach the eardrum, the ear canal narrows and then it widens again. And it normally widens anterior to the front section of the ear canal, and it creates a recess there where you can see this sticky wax, and also at the base of the ear canal it widens towards the floor of the ear canal, and you get another recess which we call the inferior recess, and it's very difficult to remove wax and keratin from there. In fact, if I was using a microscope or even the waxscope, it may not always even be visible. The cartilage is quite tender in the side. It's again rigid. Now the patient did report rubbing this ear quite a lot, which is probably the main cause behind the tenderness of their cartilage. Sometimes patients can suffer from cellulitis of the cartilage, also known as pericondylitis. So that does need treatment. If so, it can lead to a cauliflower or restless ear, I think it's called in America. Just mopping up the entrance first. Again, I'm going to use quite a lot of olive oil during the procedure. At present, because of the location of the wax, I'm not entirely sure of where the back part of the ear canal is, so I've got to be careful when I'm inserting the suction probe and lifting it away posteriorly from the back part, because I don't want to bump in accidentally to the canal wall. I just want to see a bit of flesh there now. I can see the floor of the ear canal, and I can see some skin adhesions appearing, so I know that the ear canal is in close proximity. But once I can see the back part of the ear canal, I then have full confidence in where to insert the instrument and where not to insert the instrument, more importantly. It's quite a dense plug, this. You can see it's not as occluding as the right side. There is a bit of a gap there at the roof of the ear canal for a bit of sound to go through. So I'm just going to focus on the back wall of the ear canal. Just want to gently peel away this wax to see the canal. So I'm beginning to get an idea of the anatomy now, which is really, really important. So this patient's ear canal, as opposed to being oval shaped, so most of our ear canals, they're not round, they are not circular, they're oval shaped. The height is greater than the width. So like an American football or an egg. But in this patient, the anatomy, both sides, but more so the left side, is very circular, very round. And you can see that, just like the right side, they've got this layer of skin that's enveloped the wax plug and is still adhered to the canal wall. There's a few hairs in the wax plug as well that have matted. You can see there's some of these here when I'm removing the wax with the suction probes, and the hairs visible. I'm just going all the way around, just trying to lift it off the canal wall as much as I can, just to retract it. Now, I wouldn't glide in with the right correct here because we're on the bony part, so unless it's absolutely necessary, I wouldn't want to do that. If it's more lateral near the entrance, that's fine. So I'm just going to persist with the suction. When you've got dead skin like this, you can see how stretchy and elastic it is. It really does pull for microsuction. So I'm going to put some more olive oil spray in there. You've got to be careful when you've got dead skin like that, because it can sometimes clarinet. Clarinetting is when you suction dead skin, the dead skin violently flaps at the tip of the suction probe. And when it does, it emits a very loud, high frequency squeal. It's not only loud for the patient, it's loud for myself. So you have to bear that in mind. Whenever you do get clarinetting, of course, you should stop the procedure and try to revert to a fine end if possible. But obviously, if the patient's got clarinetting now, a fine end isn't really going to help in this situation. There's too much wax, it's too dense. You can try and use a different instrument, you can reduce the suction power. You can also try and position the suction probe in such a way that you embed it more into the wax and your movements are slower. And that can sometimes also help to reduce clarinetting. The problem with this wax, if you try to embed the suction probe a bit more into the wax, because of the consistency, you can easily block it. So I'm just trying to kiss the surface here. I want to avoid the suction probe getting blocked. You can see I'm just gently trying to bring forward the more medial wax and slowly rocking it forwards, and here we are. It's got trapped at the entrance. I think the suction probe actually got blocked there, so I'm just using the suction probe as a scoop there to remove that last piece. So I'm mopping some residual wax. So again, there's some wax on the anterior canal wall. It was It was quite tricky once more to stretch open the patient's ear because the cartilage was a bit more rigid than usual. Just going to avoid touching that canal wall. I think I'm using the full zona there. The eardrum, you may have noticed, appears slightly retracted. The top part of the hammer bone, which we call the short process, the other name's also the lateral process, is the circular, spherical aspect of the hammer bone. It's somewhat protruding forwards, and then the eardrum on top of it and the pars facida, also known as the attic, it looks like it's draped over it, so it's sucked in superiorly. The eardrum, if it's sucked inwards due to negative middle ear pressure, you can get a retraction of the pars tensa. So the eardrum, there's two sections of the eardrum, the main body of the eardrum, so anything below that short process of the hammer bone, so that spherical pointy part that's protruding towards us, anything below that we call that the pars tensa. So that the main body of the eardrum, the pars tensa, is a bit more tense, a bit stronger, hence the name. And anything above that short process, we call that the pars facida. So it's more flaccid. It's thinner in the respect that the eardrum has three layers. The outer layer is made up of epithelial skin cells, so it forms the epidermis layer, the same skin that lines the ear canal itself. The innermost layer is made up of the mucosal skin that lines the middle ear, and think about the mucosal skin similar to the skin inside your nose. So it's more moist, secretory, it can produce mucus. And then you've got a middle layer made up of fibrous tissue. Now, the fibrous tissue in the pars tensa, it's aligned radially and concentrically. So it gives more rigidity to the pars tensa, whereas in the pars facida, the fibrous tissue is more diffuse, so it gives less strength and body to the pars facida. Hence why, if ever there's negative pressure in the middle ear, or if, for example, you're on an aircraft and you're descending, the cabin air pressure will push your eardrum inwards. Or if you've got a blocked eustachian tube, which is the pressure equalising tube which connects the middle ear to the back of the nose, if that's blocked and there's no air able to enter the middle ear, and all the remaining air in the middle ear gets absorbed by the cells in the middle ear, it creates negative pressure, and then your eardrum gets sucked inwards. And because the pars facida is more thinner, or less rigid and strong, less tense than the remainder of the eardrum, it's more likely to get sucked in. You can still get a retraction of the pars tensa though, so it's not unfeasible. Quite, I would say, of course, most retractions are attic pars facida retractions, but I do see quite a few pars tensa retractions as well. So I'm just mopping up near the entrance. Again, there's going to be a bit of wax here and there. It's a soft, sticky type of wax. It's just residual staining of wax. I've put a lot of oil in there. It's just a bit here on the border of the cartilage and bone, so I'm just going to glide over it with the new correct, try to get any excess oil and wax out. I'm sorry guys if the narration's a bit stop-start. I've still got quite a bad throat, so I am having to pause the narration and have a little break and return back to it. So hopefully